Hi, this is Miss Jones. We start off with urinary incontinence. Here we have, of course, to differentiate among the 4 different types of incontinence that we went through in their management. So we have stress, urge, overflow, and functional. We know, as I said, stress is the one where you have abdominal pressure on the bladder. Can occur with any kind of movement and activities. That's the one where it says, we say, don't make me laugh so much. I'll pee in my pants and stuff like that. So you have leaking with exercise, laughing, coughing, sneezing. And so the primary treatment for that would be the Kegel exercises. There can be some behavioral interventions too, and surgery if needed, but primarily we want to strengthen those pelvic floor muscles. The other one is the urge incontinence. This is the overactive bladder. This is where we have abnormal muscle contractions, and so the person has a sudden urge to void and cannot make it to the bathroom in time, so unable to hold a urine. The treatment here would be, of course, to tamper down that bladder. So the treatment will be anticholinergics or antihistamines. You can also do some exercises and things of that nature, but primarily what we're looking is something to relax the bladder wall, the bladder muscle, so anticholinergics. Overflow incontinence, the cause is incomplete emptying, which leads to leaking. This is what we say leads to bedwetting. And so the treatment here will be to correct the problem, the obstruction, and a lot of times the surgery that is needed. And then we have the last one, the functional incontinence. It does not have a urinary tract or any problem with the urinary tract as being the cause. It is something other than the urinary tract. It can be the person has a fractured pelvis, cannot move, and has trouble moving around getting to the bathroom, or has dementia. So it can be a temporary functional incontinence or it can be a permanent one. If it is irreversible, then probably what we're looking at is catheterization containment devices. If it is reversible, if it's temporary, then we're looking at some containment devices while the functional incontinence exists. Okay, the next section there is your UTI. A UTI, as you know, is an infection of the urinary tract, and it can be a lower UTI or a higher UTI. The higher UTI is also called an ascending UTI. So signs and symptoms are going to be similar for both, except we add a couple of them to the pyelonephritis. That's the higher UTI. So signs and symptoms would be anywhere from painful urination to cloudy, bloody, foul-smelling urine, suprapubic pain, the urgency and frequency for urination. They may have some nausea and vomiting, fever. And of course, we know with the older adult, confusion. And that may be the only symptom that they have is the confusion. So how do we diagnose a UTI? It's going to be a urinalysis, a urine CNS, and a blood culture. Now, if we're suspecting a pyelonephritis, we're going to do a CT scan also so that we can look at the kidneys themselves. So a pyelonephritis is going to have the same symptoms as a lower or cystitis, except that now we're going to have evidence that it has moved up, it has ascended up the urinary tract. So we have a person that will have flank pain. Now, remember that we want to recognize UTIs in a timely fashion and treat them because there's a high risk for urosepsis, especially with pyelonephritis. So the signs and symptoms of a urosepsis would be systemic signs and symptoms such as chills, a temperature elevation, maybe a drop in blood pressure, tachycardia. So those are signs and symptoms that now it's not just contained to the urinary tract. So how is it managed? For both of them, hydration and antibiotics. We are going to give antibiotics as needed. If they're nauseated, then, antiemetics. With the pyelonephritis, the antibiotics are going to be for a longer duration, up to 21 days. So it's very, very important that the patients do complete the course of antibiotic therapy. With the pyelonephritis, we're also going to monitor labs for renal function because it's up there in the kidney now, so there can be some damage. And so we're going to be monitoring renal function. Now, what would you include in the teaching plan? Well, primarily we're going to focus on how to prevent a UTI, right? For females, we know we're going to teach them to wipe from the front to the back, never from back to front. We're going to teach our patients to void. When they have the urge to void, do not hold the urine. We're going to teach them to drink plenty of water, 6 to 8 6 to 8 ounces. I'm sorry. Okay, let me start again. 6 to 8 glasses of water per day. Cranberry juice is good. It is a urinary antiseptic, so it's a good juice to take. We're going to tell them to refrain from using any body fragrances, women to refrain from douching. Do not wear any nylon panties. Make sure that they wear cotton underwear. To shower and not to take tub baths. Not to wear any tight constricting clothing. Those types of things. And of course, if they have a diagnosed UTI, to take a complete course of their medication. All right, so that's the UTI. The next one on here then is the glomerulonephritis. Remember I said do not confuse glomerulonephritis with pyelonephritis. Glomerulonephritis is simply an inflammation of the glomerulus and the capillaries, all right? And it is an antigen-antibody reaction, so it's an inflammatory response. It is in response to some infections somewhere else in the body. Usually it's upper respiratory tract. So for that reason, whenever we suspect somebody with glomerulonephritis, we're going to automatically do a throat culture. Now, what are the manifestations of glomerulonephritis? Well, they're going to be signs and symptoms of impaired renal function. So we're going to have generalized edema, the hematuria, proteinuria, and hypertension. When we're treating somebody with glomerulonephritis, besides that throat culture and starting them on an antibiotic, broad spectrum for that precipitating infection, we're also going to do UA, urine CNS, a blood CNS, and we're going to be checking renal function. So we're going to be doing Bunsen and creatinines. Also, we're going to include CBCs because we want to see, since the erythropoietin is, or their red blood cell making ability is also affected. We want to check that. And they're going to do glomerular filtration rates. Less than 60 is indicative of impaired renal function. Remember that the normal one is from 90 to 120, I think, mLs per minute. But less than 60 mLs per minute is indicative of impaired functioning. So, how are we going to manage it then? We're going to, of course, decrease the inflammation. We're going to give corticosteroids. Remember that anytime that you have a disorder that affects the kidney functioning, we never want to give NSAIDs, all right, if kidney functioning is impaired, because NSAIDs will reduce the renal blood flow. So we want to stay away from that. We want to maintain a fluid and electrolyte balance for this patient. So the patient may be receiving diuretics. The patient may be on a low sodium diet if they have hypertension and edema. They may also be on a fluid restriction. And of course, as I said, that antibiotic for the suspected infection that caused this antigen-antibody reaction in the kidneys to start off with. Polycystic kidney disease then is the next one on here. Polycystic kidney disease is a genetic disorder, and what we have are cysts that are forming in the renal tubules. This, of course, leads to renal failure. Usually the signs and symptoms of PKD develop in when a person's in the 30s or 40s. So what are the signs and symptoms? They will be signs and symptoms of renal failure because that is what's happening. Plus they will have pain. If you palpate the kidney, you will feel an enlarged, lumpy kidney because of the cysts that are forming. So, of course, who is at risk for PKD? If there anybody that has a family history of PKD will be at risk and should be tested to see if they are carrying the gene. So how are we going to manage it? We're going to manage it like we would manage renal failure. Of course, avoid those NSAIDs. We're going to put them on daily weights. We're going to have them on antihypertensives because it is painful. We're going to do pain management. So it's very important that we avoid those NSAIDs. They're going to be low sodium, fluid restriction. We're going to, of course, monitor their renal functioning. So BUN, creatinine, protein, checking for proteinuria, hematuria, and any generalized edema or what we call anasarca. Remember that the final outcome for somebody with PKD is renal failure, end-stage renal failure. So somebody that does have it is going to be looking at progressively getting worse, being on hemodialysis, and then requiring a kidney transplant. Okay, urinary retention is another disorder here, and of course it is the inability to empty the bladder. So it will be whatever causes, the bladder to be unable to empty completely. Hold on a second. All right. So well, the bladder usually holds from around 400 to 600 mLs of urine, but with urinary retention, it can expand up to 2 to 3 liters, so that's quite a lot of urine. Remember that the problem is an outlet problem. The kidneys are functioning fine, so they keep producing urine. So the problem is right there that we cannot open up the faucet, so to speak, to empty the bladder. So what are some of the causes? There's a variety of causes. It can be kidney stones, fecal impaction, BPH, prostatitis. It can be from medications such as anesthesia. It can be tumors or clots in the bladder or spinal cord lesions or injuries. There's a lot of different causes for urinary retention. So the biggest problem with urinary retention, prolonged retention, is of course that it leads to what we call urine stagnation, which increases the likelihood of UTI and the formation of stones. So we do need to take actions to empty the bladder. All right. So what would you find in somebody that is having urinary retention? Well, a large palpable bladder, but nowadays, for luckily, that we use the bedside scan, the urinary scan, the bladder scan. So that makes it a whole lot easier not to palpate the bladder because it is painful to the individual. Of course, suprapubic pain, the urge and inability to void, and if they do void, it's just in small amounts of about 25 to 50 mLs. And we know that the output's going to be grossly disproportionate to the intake. There will be increasing restlessness and agitation as the bladder enlarges, and of course, increasing urgency to void. Remember that we're always going to go for the urinary catheterization first. So review all the steps that we do in trying to get somebody if it's something like anesthesia, maybe something as simple as getting them up and ambulating them. But the things that we do, to get them in the proper position, to natural voiding position, try the water technique, flowing water, so that we try to stimulate. And the in and out catheterization will be the very last action that we would attempt. Okay, the next section on there are kidney stones. Kidney stones are of a different variety. They're simply a clumping or a mass that forms from these crystals that clump together, and it can be made up of calcium, which is the most common type of stone, uric acid stones, and of course the struvite. The struvite stone occurs with urinary tract infections. Okay, so what would you, I know I have here the teaching plan and stuff, but let's talk about what are the signs and symptoms of a kidney stone. The number one sign or symptom actually is pain. Severe pain, and the pain is going to move along with the stone. So if it's a high stone, say in the pelvis of the kidneys or somewhere in the kidneys, they'll have flank pain. As it moves on down and gets down to the urethra, actually they may actually feel pain in the groin area. A person may have kidney stones and not feel anything. It's when it gets embedded or goes through a narrow passageway like the ureters or the urethra, or it gets embedded in tissue like the kidney pelvis, that pain is elicited. That stone, if it's large enough, can actually also cause that pressure on the structure there and cause some necrosis. So besides the pain, it's very important to treat it because it can cause damage. And so how do we treat it? We have some medications that are designed to decrease stone formation or promote the breakdown, such as allopurinol for uric acid stones, antibiotics for struvite stones. If somebody has calcium stones, we're going to look at their calcium levels, their calcium intake, and approach it from that perspective. Sometimes patients will receive, and this is orally, not IV, bicarb, and that's to make the urine more alkaline, because alkaline urine discourages the formation of stones. Okay, so the other things that the patient may be suffering besides pain is that they may be nauseated, they may actually be vomiting, and they may have blood in the urine, hematuria. And so how are we going to diagnose it? We can do abdominal x-rays, or CT scan is the usual way that we go, or we can even do an IBP. But once we have it diagnosed, we do want to get a sample because we want to identify what type of stone we have, so doctor can go ahead and decide how to treat it. So if it's a uric acid, we also look at diets. Remember, so it's going to be a low purine diet. If it's calcium, besides, we're going to decrease the calcium intake and make sure that they have a low calcium diet. If it's struvite, we're going to reinforce our teaching to prevent any recurrence of UTIs. All of them, we're going to push water. We want them to hydrate to encourage the flushing of the stones. If the stone is not passed, we don't pass the stone by itself. Surgery, well, not surgery, but lithotripsy may be needed. The lithotripsy, of course, we administer ultrasonic waves to break up the stone into smaller ones. We do not get rid of the stones. We just break them up so that it's easier for the person to pass the stones. It is very, very important that we teach the person to drink lots of water post-procedure to flush the stones. And of course, we need to teach the person how to strain their urine too. If the stone is in a place, or stones are in a place where lithotripsy is not an option, then the patient may need to have the stones surgically removed, okay, with an open surgery. Now, this will be an open kidney surgery. They may do it laparoscopically too, but if they have an open kidney surgery, of course, now we have the post-op care. We have a person that will have a dressing that we have to take care of. We have a person that we have to recover post-operatively. So all the interventions that are applicable to a post-op patient will be applicable here: the turning, the coughing, early ambulation, coughing, and deep breathing. We need to also monitor this person because they will have a nephrostomy tube in place that goes into the pelvis of the kidney to drain fluid from the surgery and, of course, urine. And so we need to make sure that it is patent. There are no kinks. It is well secured. There are no big dependent loops in the tubing, so there's no backflow of this urine back into the kidneys. We need to manage the pain because it will be painful. They will have pain at the site. And then they're at high risk for infection, so we need to monitor for infection. Okay, from kidney stones we go to renal vascular disease, and also in here we have the nephrosclerosis, just two little disorders, okay? Renal vascular disease occurs when the renal arteries are severely narrowed and therefore they reduce the kidney blood flow. This can lead to ischemia and atrophy of the kidney tissue, all right? So it can also lead to what we call renal artery stenosis, all right? Or that's what's happening actually. So how do we manage it? Well, usually the people that have renal vascular disease also have arterial disease and stuff. So we want to manage the blood pressure. We want to make sure that their blood pressure is not elevated. They may actually go for procedures just like you would for the coronary arteries. They go for procedures for the renal arteries. They may have stents inserted, or they may have a balloon angioplasty, or even a renal artery bypass surgery. Okay, so that's how we treat it. The nephrosclerosis then is sclerosis, just like it happens with atherosclerosis, or it's the thickening of the nephron blood vessel. So again, it leads to a narrowing of the lumen, can lead to ischemia and fibrosis. So we know that nephrosclerosis occurs with hypertension, and actually people that we do not see it in folks that do not have hypertension. We do see it with hypertension. We see it with atherosclerosis and diabetics. So how are we going to manage it? Well, since we see it with high blood pressure, of course it's going to be focused on controlling the blood pressure. We also want to preserve kidney function, so we're going to be monitoring that kidney function. The person may be on ACE inhibitors and diuretics to treat the high blood pressure. Okay, the next section here is on BPH, enlargement of the prostate gland. It is a disorder that is commonly seen in elderly men, and actually they say that one of the risk factors for BPH is obesity. All right, it seems to play a role. We don't know the exact cause, but we do see a relationship between obesity and BPH. So, knowing that we have this enlarged prostate tissue, which is at the neck of the bladder, right? We are going to have a lot of urinary symptoms, all right? So what are some of the signs and symptoms of BPH? Well, the person may have difficulty initiating the stream, and once they initiate it, maybe a weak and dribbling stream. They may suffer from nocturia. When they do void, they will void in small amounts and not feel that they have completely emptied the bladder. They'll have an interrupted, weak stream, hesitant. They'll be feeling this urgency to go void and maybe leaking or dribbling urine. They tend to strain a lot when they void, all right? For this reason, we tell them to void when they have the urge to void. We don't tell them go try to void every 2 hours or anything like that, because we're just increasing the episodes of them straining. All right, so we tell them void when they feel the urge to void. The other thing, of course, we tell them do not hold back on water. Do not limit your fluid intake. Okay. They may also have some hematuria, and of course, because they have problems with urinary retention, they are at risk for UTIs and formation of stones in the bladder. We do teach them to stay away from cold or allergy medicines because they can have acute urinary retention, which will be triggered by this cold medications or allergy medications. All right. So, how do we treat it? Well, they will try medications that will reduce the prostate size and, of course, decrease the urinary problems. When they get these medications, we do need to monitor for orthostatic hypotension, and we need to teach them to slowly change positions, right? And again, don't be making mad dashes to the bathroom to void when they feel the urge to void, and not be increasing the number of trips to the bathroom because it just increases the straining that they have. All right. If medically, they can't correct or they can't sufficiently help the person by treating it medically, then we're going to look at surgical intervention. And there are lots of different procedures that can be done. We're going to focus on the TURP. All right, that's the main procedure that we're going to look at. That's the transurethral resection of the prostate, TURP. All right. So you would need to prepare them like you would for any other surgery. The biggest issue with the TURP is the post-op care that is required, all right? There is an increased risk for bleeding post-operatively. They will come, and it's the surgical, I call it the Roto-Rooter procedure. It is done retrograde, which means there's no incision. They go in through the urethra, and they actually shave off the tissue, the prostate tissue, and create an opening or a widening of the urethra. All right, so they will come out with a double lumen catheter, and they will require continuous saline irrigations post-operatively to flush, the bladder and to prevent any clot formation. So it's very important. Initially, when they come out, and they're these big bags, 3-liter bags of normal saline that we hang up at a time. It is very, very important that the system is always patent and it's always draining well. So at any time the draining stops, you are to stop the irrigant and notify the physician right away. All right. So what do we expect initially? Initially we expect a lot of blood clots, and it's going to be red, like, fresh surgery, bloody coming out, but it pinks up pretty soon. All right. So we need to continuously be monitoring for any signs and symptoms of bleeding with a TURP. All right. So what are some of the things that we do in monitoring for any bleeding? Of course, we're going to monitor for clots, all right? The patients actually that are on this irrigation, sometimes we do manual irrigation when we have a lot of clots. It needs to be a septic procedure, all right, when we do manually irrigate. But we want to keep the flow going, the irrigation going in, and of course draining out. So we need to be very careful with our intakes and outputs. And with the output, always subtract the amount of saline that has infused. All right. So like I said, post-operatively, the outflow will be bright red at first, and then it will lighten up. If at any time it reverts back to being bright red, or it is thickened, viscous in nature, you need to notify the physician. It may be a sign of a fresh bleed. Okay, so there's that risk for bleeding. Let me see what else that I have here. Primarily that's it. It's a lot of monitoring with the bladder irrigation that we have surgically. And it is painful, if you can just imagine having that bladder pain. So pain management is very important for our patients too. All right, now, sometimes they cannot reach the prostate tissue by doing a urethral approach, right? Or retrograde approach. So they have to do open surgery. They are going to do a prostatectomy. So they're going to go through the bladder to get to the prostate. And so they do it by a, excuse me, open, or what we call suprapubic prostatectomy. In those cases, is like I said, they're not able to reach the bladder, the prostate, or there's been bladder damage that has occurred, or it's a very, very large prostate, and they have to use that approach. So you will have a lower abdominal incision with a prostatectomy, and you will have a suprapubic and a regular Foley catheter post-operatively. They tend to have a lot of bladder spasms, so they need to be on medications for those bladder spasms. They also have a high incidence of incontinence and erectile dysfunction. Patients with TURP also can have incidence of residual erectile dysfunction or incontinence. And oftentimes we put the prostate patient post-prostate after they've gone through all the recovery and they're healed through doing Kegel exercises to treat the incontinence. Now, remember the person that has a prostatectomy now has a surgical wound, all right, a suprapubic wound. And so we need to teach them post-operatively what we would teach anybody with a surgical wound, and that's to avoid baths, to only do showers, and how to care for the wound, how to monitor for infection. So no baths for this person. We also, says probably they will go home with a catheter in place. We need to teach them how to care for the catheter. Excuse me, the catheter, we care for it once a day. We wash it with soap and water. There's nothing special that is required in cleaning. Okay, the next section on here is bladder cancer. I have several topics. I know I have testicular cancer, but I'm also going to talk about erectile dysfunction and the orchiectomy with a testicular cancer. So bladder cancer, just a few items, right? The most common cause for bladder cancer is smoking or tobacco products. That is over family history, over any other risk factors. It's the smoking. Secondly is if they're consistently over a prolonged period of time, and the smoking is over a prolonged period of time, they are consistently exposed to environmental biochemicals or chemicals. Remember, the kidneys are the ones that remove any toxins that go into our body, and so that means over years and years of time we have these toxins that are being filtered out by the kidneys, and of course they're going to sit in the bladder until we void. All right, so there's this continual exposure of the bladder wall to this toxins, all right? But smoking is the number one. What are the signs and symptoms of bladder cancer? It might be pain with urination. It might be blood in the urine or cloudy urine. They may have increased frequency and urgency. And of course, what's going to be required, just like with any other cancer, treatment would be chemo, radiation, and or surgery. Testicular cancer is rarely, one of the things is that primary testicular cancer is rarely bilateral. So we're talking about only one testis being affected. It is painless, and usually what the person will feel is a heart swelling or enlargement of the involved testicle. So it's very important, just like with breast cancer, it's very important that we teach our male clients to examine their scrotal sac on a monthly basis after a bath or a shower when the skin is relaxed, and they can They can examine or feel the scrotal skin a whole lot easier for any lumps, the texture of the skin, any smooth rounded masses, or change in size of the testicle or the sac. All right. Now, how do we treat testicular cancer? Well, we treat it surgically. It's removal of the involved testes, an orchiectomy. That's the main type of treatment, and usually that's the approach that's used. So you need to look at post-op care of somebody that had an orchiectomy. We need to teach them that they cannot shower for about, that they can only shower, all right? And they can start showering about 1 to 2 days after surgery. They may be required or may need to wear scrotal support. We need to teach them to avoid any lifting over 15 pounds, to avoid stair climbing or driving vehicles until they are cleared by their doctor. And this is usually several weeks, that first post-op visit, 6 to 8 weeks later. But they need to avoid that until they are cleared by the physician to do so. All right, that's with testicular cancer and the orchiectomy. The other thing that I don't have listed here, and you can write in here real quick, is erectile dysfunction. Erectile dysfunction, we all know what it is. We see all this commercials on TV about it. One of the things is that we can treat it medically. We didn't used to be. They used to use some devices to treat the erectile dysfunction. But now we have medications. And medications that will smooth muscles in the corpora cavernosa, or the blood supply of the penis, and so the blood flow is increased, and therefore we have swelling and we have an erection. I mean, the patient has an erection, all right? So medications like they're long terms, a common one, we go by the acronym of PDE-5 inhibitor. So, most of the medications for erectile dysfunction, we teach the patients to take it 1 hour before intercourse, and of course we know that they are to seek medical attention if the erection lasts for 4 hours or more. We also teach them not to take alcohol when they are taking the medication because it will impair their ability to actually have an erection. And we tell them to go ahead, if they are on nitrates or, for cardiac problems, to avoid taking the medications, okay, because it can produce profound hypotension, actually, that will reduce blood flow to vital organs. So we're not just talking about orthostatic hypotension if persons are on nitrates and they take a medication for erectile dysfunction, all right? Anyway, so that's about it, I think, and that's a good thing because I have a scratchy throat and I'm starting to lose my voice. So this is your recap for Unit 4, and as usual, if you have any questions or anything like that, please email me to let me know or ask me a question. I will promptly answer you. Thanks.